Good afternoon, everyone. I'd like to welcome you all to today's ECHO session. And today we'll be discussing a very interesting topic. We'll be looking at management of patients that are failing second-line ART. To help us discuss this topic today, we have our didactic presenter, that is Dr. Sivile. He's an infectious disease specialist, and he's based at the University of Maryland. We also have some subject matter experts that have joined us here from both the pediatric and the adult center of excellency in the hub, and they'll be also giving their input regarding the topic. We are later on going to have a case presentation from Sons of Thunder, but before I proceed, I'd just like to acknowledge everyone who has joined in today, and I welcome you all, and I urge you to participate freely. So I guess if you can hear me, you could just kindly wave. For those that can hear me, you can wave. Okay, thank you very much. So before we proceed with today's didactic presentation, I am going to ask Dr. Mpeta to give us a recap on what we discussed last week during the ECHO session. Dr. Mpeta.
Thank you very much, Dr. Kanjiwa. So last week we were basically talking about strategies of reaching men with regards to the control of the HIV and AIDS. So we discussed various strategies. And first of all, we started by identifying the barriers in that the setup of our clinics mostly, I think, are not male-friendly. And we find that a lot of men do not have the opportunity of going to clinics quite as often as the female counterparts. The other barriers that were identified or discussed is that there's the aspect of ignorance and self-stigma with regards to men, and the assessment of risk rather than downplaying their risk in terms of them acquiring the HIV and AIDS. Among the notable strategies that we discussed were trying to come up with friendly hours for reaching men, like after hours or even early morning pickups and clinic reviews. The other strategies were self-testing kits and index testing, which were also identified as high-yielding strategies in terms of reaching men. So we also were also advised that we need to include men in the differentiated service delivery modes so that we can reach as many men as possible. So basically, that's what we discussed last week.
Okay, thank you very much, Dr. Mpeta, for that recap. I think last week we had a discussion on why we are focusing on finding men. We know that men are a priority population when it comes to controlling the epidemic of HIV. So I think at this point, we will move on into our didactic presentation for the day. So I'll ask Dr. Sivile to just quickly introduce himself as we move on to the presentation.
Good afternoon, everyone. I'm Suilanji Sivile. I'm an infectious disease doctor, and I'm with University of Maryland. I was asked to give a presentation on second-line treatment failure. Can I continue? Okay. Okay, I hope you can see my slides. So that's my name and no disclosures. Yes, so, and those are our learning objectives: to define treatment failure, to look at the causes of treatment failure and second line in particular, and to explain the approach to a patient suspected of second line treatment failure and just treatment failure as a whole. And we want to outline briefly what happens on third line when a patient is taken to third line. Next slide.
Okay, so before we proceed, we are going to go into we're going to tackle our first core question. And the question is, which of the following statements is true regarding ART treatment failure? So pick the best answer. A, it is defined as a detectable HIV viral load after 6 months on therapy. And B, treatment failure implies that the drugs are not working. C, It is often associated with virologic failure, immunologic failure, and or clinical progression. Or D, clinical treatment failure tends to precede virologic failure.
So that should be easy.
We'll be launching the poll now. We'll give you a few seconds to just vote, pick which one you think is the best answer. Okay, so far we have 5 facilities, participants that have voted. So we want you to pick the statement that you think is true regarding treatment failure. Okay, so the majority think it's C, and we have 12% that think it's A. From the hub, we can also have an answer in mind.
You have to mute, because they'll copy our answer.
Okay, so 68% of the facilities and participants have voted. Okay, so the options are split between A and C so far. Okay, we'll discuss the answers at the end of the presentation. So, Dr. Sivile.
Next slide.
So, next slide. Okay, Dr. Sivile, you can continue.
Okay. All right. We'll start by looking at the definitions of treatment failure. I can give you some leakage. I've noticed that most of the people know what we are talking about from the poll questions. So one famous infectious disease physician, Michael Sagg, says treatment failure or failure to therapy is actually a relative matter. And it's only when that patient comes very sick, sometimes at the point of death, in your office or in your screening room, then you realize that the patient was actually failing treatment, something that we don't want to have. So according to the DHHS guidelines, says that, you know, they define treatment failure as suboptimal response to therapy. And treatment failure is often associated with virologic failure, immunologic failure, and clinical progression. You know, I have, you know, underlined I've put in both the word therapy, and this is probably one of the main points that I want to share with everyone, that what does it mean, therapy? So there, the word therapy does not only restrict to drugs, it will mean the holistic handling of that patient that you receive. So it will include things like, you know, social demographic issue, psychosocial issues of the patient, behavioral issues, and even health systems issues, you know. So all those issues will lead to actually the patient failing treatment. The rest of the things, I think we know them. Clinical failure will often involve stage 3 or stage 4, WHO, you know, clinical stages. Immunologic failure is difficult to define, and it's one of the things that we try not to spend much time debating what it is. But it's important to note that the patient who has virologic failure, if the viral load is like 5,000, you know, somewhere there, usually they will not, you know, rapidly progress to clinical failure. So you might not see it initially that the patient is actually failing. And those patients could even have mutations at those very low viral loads. Next slide. So this slide is just to show you some key points that I would like to share with you. The first one is what we expect to the viral load. The decay of the viral load when someone is put on treatment. So this is an old study done in about 1999. So it might not be true, especially that now we have quite potent drugs like dolutegravir. But after 6 months, we expect the viral load to have dropped by about 5 logs. So if someone had a viral load 100,000, it should be undetectable at that point. But the critical questions that one should consider when handling a patient who has clinical failure, the most important question is to ask yourself as a clinician, why has the patient failed? What is the cause of treatment failure? The next one is there resistance in this patient? And if there is, what sort of resistance has evolved? And we'll spend some time discussing this. So treatment failure is not the same as not taking drugs. Often I see patients in the clinic, they'll come and the report they have from the caregiver is, they'll speak either in Bemba or Nyanja or whatever, ati Mukwala Susebenza. This is not true. It's not that the drugs are not working, the drugs are not optimally working. So there's a difference, and I'll explain why that difference is very important. So patients who discontinued treatment also have treatment failure. So most of the time, people restrict treatment failure to only those people who are taking drugs, and the drugs, the viral loads are not fine. But even the gentleman or the lady who has defaulted or is lost to follow-up if they're alive, that should also be included in treatment failure because the therapy hasn't been successful at that point. So those are some key points that I'd like to share with you. Next slide. So this table was just there to show you that the second line that we use actually would require several mutations, especially in the PI, for it to stop working. Just to emphasize the point that treatment failure is not equal to drugs not working. If you see in the first row there, if someone has got 0 or to 2 mutations, you find that the potency is somewhere between 70 and 90. The drugs are not working optimally, but they are working in a way. So it should be understood from that angle. And the other point from this table to note is the protease inhibitors that we use in second line, they're quite durable, and they have that high, high resistant barrier, as we call it. So it's, in other words, it's not easy for a patient to actually fail. That's why you need to look at the reasons why this patient has failed our second line therapy. The next slide. This slide was just to emphasize that, once you think the patient is failing, it's important to continue the patient on the same therapy. Because like I pointed out, even when the patient has failed, it doesn't mean the drugs are not working. So this was a study, I think a famous one, the so-called lamivudine monotherapy. And you can see from the Kaplan-Meier, especially on the left side, my right side there, that patients who are maintained, even on just lamivudine, if they continue taking their drugs, even if they are failing, they will have a better survival rate, and clinical parameters like clinical failure and immunological failure will delay compared to those who you remove on therapy completely. So the point here is, even if you are out there, wherever you are, in a remote place, if you think the patient is failing treatment, it's important that patient stays compliant to that same treatment they are on. Next slide. So this is just another study that emphasized that not all patients who fail therapy actually have resistance. We shouldn't equate treatment failure either to first line or second line to resistance. So this is a study done in Vietnam, and I liked it because it does present it just deliver the point that I have. What I've highlighted in yellow there, it shows that these individuals, had failed treatment after maybe about 2 years of therapy, and these people resuppressed. And when they went in to look at the individual viral loads, they find that almost all of them had about, genotype, they had about a single PI mutation, and they were able to resuppress. Again, delivering the point that treatment failure is not equal to resistance, and someone who's on treatment failure should continue the same therapy. And we see here that not everyone who had treatment failure had PI mutations. In this study, only 64% of patients had, major PI mutations. The rest, actually, the drugs were susceptible. And this is a point that we see in the third-line clinic. People sent from far off places. When we do a genotype, we find that the drugs are not working. And you wonder if due diligence was done before this particular patient was sent. So treatment failure is not equal to resistance.
Okay, so we're going to launch our second core question. And the question reads, when a patient is suspected to be failing second-line ART, collecting a blood sample for genotyping is the first and most important thing to do. So, do we think it's true? That is option A. Or do we think it's false? So we can vote. Okay, so we have two options there. Do we think the above statement is true, or do we think it's false? Okay, the majority think it's false. We can keep on voting. Okay, 67% are going for false, and we have about 32% that think it's true. When you suspect someone is failing second line, the first thing you have to do is collect a blood sample for genotyping. Okay, we have a couple of seconds to vote.
And the hub is not voting.
The hub, we can also discuss. Okay, we are going to end the poll now, and we'll discuss the answers later.
Okay, so that was interesting. About 40% think it's true, 60% thinks it's false, so it's quite kind of close. Yeah? Yeah. All right, it's a tie probably. Yeah, so, all right, so what are the causes of treatment failure? So this slide is very important. So mainly, there are two causes that will cause failure to arise. One side, you have potency issues, that is the drugs are not working. The other side, you have the drugs are not being taken, adherence problems. And these will cause virologic failure, and this can cause resistance, immunological failure, and clinical failure. And indeed, I must say that there should be an arrow on these slides straight from virologic failure to clinical or immunologic failure without going through genotypic failure, because not everyone who fails actually has drug-resistant mutations. Yeah. Next slide. So some of the causes of potency failure were listed on the other side. I wanted to just explain that when you look at potency failure, sometimes you can be really thought into those who had prior exposure to ARVs, and we know these were probably who were on treatment previously, those who've used PrEP, those who were probably infected with a resistant virus from someone else who was on treatment, issues of single-dose nevirapine, and indeed drugs can be expressed for pediatric populations in the maternal, in breast milk. But you can also have resistance which can arise where you have potency problems due to non-adherence, drug-drug interactions, indeed another very important cause. Wrong dosages, they happen commonly in pediatric populations, but we see those in adult population as well. Malabsorption and just inadequate potency of the drug. Some combinations just can't work. Next slide. I wanted to spend a bit more time on adherence issues because this is the main cause. You saw it was in red there. The main cause of treatment failure. And it's a pity that we still struggle with adherence. I'm sure 2 weeks ago we saw the numbers that Dr. Mulenga shared with us, where we see almost 120 or is it 20,000 people falling off in Lusaka from treatment. But we have a lot of data, as why patients fail from treatment. And sometimes we don't take time to use this data, and maybe predict which type of patients will fail. So from a lot of work, even some systematic reviews, these are some of the 5 things that come up. The first one is dissatisfaction with health facilities and healthcare workers. So that comes on top, why people fail and they don't come to treatment, they don't continue, they default, whatever word you use. Some behavioral issues, use of alcohol. We know that males fail easily than females, and this data is consistent. Even in our third line, you find that we have more males than actually females. Yeah. Use of traditional herbs or medicines. We know, the common brands that we have in the country that when people fall off, they'll tell you they're using those brands. Then you have these psychological, social-psychological issues, which are really important. Issues like depression, very common in our patients, not attended to. Discriminations, we have keep-ups among ourselves, stigmatization and indeed self-stigmatization, and just poor social support. So these are important, But we should note that we do have promoters of adherence, and we know that good counseling and education interventions, does improve someone to adhere to treatment. And so all these people that are falling off from treatment, the question that comes, do we counsel them? Are we educating them enough? Because we know that does make a difference if you counsel a patient properly. So if there's any message that I'd like you to take from this presentation is that as clinicians, let's take time to take care of to talk to our patients. And when these patients come to third line, there are no special tests, no special drugs that are given, but we take time to talk to these patients. People who spend time in the third line will tell you that sometimes you spend 2 hours with one patient, hearing their stories, and that makes a difference, both from personal experience from physicians and even just from studies, as I've alluded to. So you do have just these general causes of treatment failure. This was from the CIDR's work. I'm sure most of us knows the Beta Info study, and we're looking at from the health system's point of view. Next slide. Yeah, these were like the 10 reasons why patients fall off. They stop taking drugs, and all of them had something to do with health systems and the behavior, the behavior of the clinicians, and they are quite exciting to look at and educative. So in other words, we can make a difference. Sometimes we think the burden of taking drugs is on the patients, but from studies, you kind of think that the big burden, to whether the patient is going to take the drugs or not actually lies on the healthcare provider. We have a lot to do in terms of ensuring that these patients do take their drugs. Next slide. So in third line, our experience, at least at UTH, is that the most common causes of why patients fail the second lines are these: inaccurate drug sequencing, drug-drug interactions, and very poor adherence. So if someone fails third line, it just signals that the adherence was very poor. Not only poor, but very, very poor. Then you have these inaccurate drug sequencing. So this is a patient who was started on TLE or tenofovir, then was switched to, for some reason, abacavir and lopinavir, you know that you are actually doing a monotherapy. So things like that. Someone was on AZT for a long time with a lot of mutations, and they are switched to ABC or tenofovir-based second line. So that kind of sequencing makes you prone to fail the third line drugs. So I'm sure we've seen some cases, some previous cases here, where the patient wasn't switched properly, and that will result in treatment failure. Then you have drug-drug interactions. The common ones is actually the lopinavir or atazanavir with rifampicin. We've said it time and again. Patients who are on atazanavir should not be given rifampicin. And patients who are on lopinavir, you double the dose if they're going to be on rifampicin. If this is not done, the patient will fail that PI, and you are sending the patient to third-line therapy. So what's the approach to patient who's failing second line? There are two main things to think about. As I mentioned, the first one is you need to come up with a diagnosis. You need to diagnose that treatment failure. And we use a viral load. We know the definition is 2 consecutive viral loads above 1,000 in someone who's been on therapy for at least 6 months. But the diagnosis of treatment failure must be complete, and it should give the reason why the patient has failed. So this is very important. If this is not done, the therapy, whether you put on patient on 3rd, 4th, or 5th therapy, whatever is available, the therapy will not be successful if you don't know the reason why the patient has failed. The second one is to assess if there is mutation. This, you use a genotype, obviously, but you can also get the idea from a good history. So it's very important to take time to talk to your patient and who has failed third line, because this is the only way you get the information to fill or to answer these 2 questions. Next. So I just put an example of what I consider a complete treatment failure assessment, and that includes why the patient has failed. You can see there, we think the patient failed due to drug-drug interactions, and you also give us an idea of whether the patient is severely immunosuppressed or if they have opportunistic infection. Again, a good history is a source of a good diagnosis. You don't talk to your patients, you won't get a good diagnosis. Next. So we do have guidelines. I know they're not so popular for third line, Zambian guidelines published in 2015. So this is just a copy, and I think they are there in circulation, just to show that the guidelines are there, national guidelines. Next. So these guidelines give us a referral system, how we should handle someone who is failing third line. And the way they were designed is to send the sample first before you send the patient. So, and this is being done in some parts of the country. I must say in other parts of the country, it's not being done. So you have a health facility there, then you have a level 2 lab. These will be hubs or maybe a nearby level 2 or tertiary hospital that cannot do genotypes. But what we advise is you make arrangements so that the genotypes are sent to the ATC lab, which is in UTH, and now we have another lab in Arthur Davidson. So these are the 2 labs. Those on the northern sides, they send samples to Arthur Davidson. On the southern side of the country, they send the samples to UTH. So the guidelines there, they do specify the courier system that is supposed to be there, and you can see there, you send the samples, then the results will be sent back until we confirm that this patient is actually failing the second line. Then you can send the patient for care. So remember, we have this referral structure in place. Next. So, and because you need to send a sample first, I wanted to give a bit of tips on collecting a genotype sample. So remember that the genotype sample must only be collected from a patient who has been taking medications for at least for at least 1 month. So if someone is a defaulter, they are not taking any drugs, that's not a good time to collect the genotype test, because what you'll be amplifying will just be a wild type. You will not be able to pick the mutations that you are looking for. So counsel these patients, you know, like the question said, the first thing you do, you talk to this patient, try to know why they failed, if they're taking the drugs, and if they're not taking the drugs, put them back on the drugs. And after you do that, you know, after a month, that's when you collect a genotype. You know, then you have a good result. So storage, processing, and transportation of the genotypes must be done by a trained laboratory personnel. So we know that they must be stored. The samples must be stored at -20 to -40 degrees. You can transport them. Usually we prefer on a nitrogen container. You know, if you don't have dry ice or maybe just ordinary ice, but you need to take care. You know, the sample should be pre-processed, you know, and it should not be stored where, you know, in heparin bottles. Yeah, but the guidelines are there. The lab people, they know how these samples must be handled, you know. And it's very important, if at all you are sending either a sample or indeed a consultation or a patient to the ATCs, that you give a full medical history of this patient, you know, a comprehensive medical history. It will be helpful. Otherwise, we've gotten calls where, you know, whose history is scanty and you can't deduce anything, you know, to help the patient. Next. So, the treatment for a patient who's failing second-line treatment, patients are treated at ATCs, Advanced Treatment Centers. So we have 3 now operating in Lusaka, that's at UTH, in Livingston, and also in Dola Central Hospital, and that's at Davidson. Yeah, so these are the places where these patients should be managed, you know, and still the principles are the same. When you are choosing the drugs, 3 antiretroviral agents, of which at least 2 must be fully active. You know, the choice of the ARVs is based on genotype results and also the history of the patient. You know, laboratory monitoring is similar to that in second-line treatment, but clinical reviews are more frequent in these patients because we need to keep an eye on this particular patient, especially that they failed 2 lines, you know. So these are some of the drugs that we use in third line: Darunavir, Ritonavir. This is a protease inhibitor, very well-tolerated drug. You know, it's different from other PIs. It doesn't have the GIT effects, doesn't have the jaundice. You know, a few patients might get some rash, but it does have the metabolic side effects like, you know, hyperlipidemias and the like. You know, then we have our dolutegravir, of which we've discussed a lot here. Raltegravir, you know, we are switching people from raltegravir to dolutegravir, but we'll continue using it. And etravirine, which is actually an NNRTIE. It can be used, etravirine, in some patients who failed, you know, NNRTIs like nevirapine or indeed efavirenz, depending on the genotype results. So in summary, second-line treatment failure does not always equate to the presence of drug resistance mutation and will arise from one or more components of patient management. And these, like, you know, social demographic issues, psychosocial issues, behavioral issues, health systems issues. When these fail, you have failure, you have treatment failure. So patients who fail second line usually have a long treatment journey, and we need a comprehensive assessment as to the reason why the patient has failed. So treatment failure itself is not a diagnosis. It needs that surname, you know, why the patient has failed. So take-home message: do not collect genotype samples if the patient is not taking the medicines, you know, and we need to understand and adhere to the national referral systems, you know, how to store, how to transport, and how to collect these genotype samples. That's all I had, and those are my references.
Thank you very much, Dr. Sivile, for that very detailed presentation on how we can, on the approach of managing patients that we think are failing second-line ART. I think it's easy for those that are failing first-line because everything is, written down in our guidelines, but oftentimes we get stuck when we have a patient who's failing second-line, and we have been given the guiding principles. One thing that I picked is before we diagnose treatment failure, as clinicians, we have to ask ourselves a few questions. Is the patient taking their drugs? If they are, what do we think is the cause of the failure? And then we also have to think, is there resistance that has developed? And that taking time to talk to our patients about the drugs, how to take the drugs, can actually delay the development of treatment failure. Before we get comments from the network, I just want to relaunch the poll questions and see if we have picked a thing or two from what has been discussed so far. So we'll start with the first question. This is how we had initially voted. So which of the following statements is true regarding ART treatment failure? So I am going to relaunch the poll just to give us a chance, to try and have a second go at the statement that we think is true. So I have relaunched the poll, so we can just quickly vote. Okay, so we only have three participants so far that have voted. So I'll just quickly read through which of the following statements is true regarding ART treatment failure. So we have option A, it is defined as a detectable HIV viral load after 6 months on therapy. And then second one, that's B, treatment failure implies that the drugs are not working. So far we have 0% votes for that. And C, it is often associated with virologic failure, immunologic failure, or clinical progression. And we have option D, clinical treatment failure tends to precede virologic failure. Okay, so the majority have gone for C. I'll end the poll and ask Dr. Sivile to just comment on the answer.
Yes, so the first answer, it's defined as a detectable HIV viral load, after 6 months of treatment. This is partially correct, not correct at all. Yeah, I think the catch there is the detectable, so we still put the viral load at 1,000. So this is, and after 6 months of therapy, if the viral load is is above 1,000. The second one, I think I explained that treatment failure is not equal to the drugs are not working. We need to make a lot of effort to change this conception, especially for our patients. C is the correct answer, and D is incorrect. Actually, clinical failure is the last event that you expect.
Okay, thank you very much, Dr. Sivile. I am going to relaunch the second poll question. Okay, so the second question reads, when a patient is suspected to be failing second-line ART, collecting a blood sample for genotyping is the first and most important thing to do. I think after our discussion now, we'll probably have some insight as to how we should proceed. So we can quickly vote, and then Dr. Sivile will comment on the results. Okay, so we still have a number of people. I think the answer is A, that the first thing we need to do is collect a sample for genotyping. Okay. We'll give it a few seconds. Okay, so 75% think it's false. Okay, we'll end the poll now, and we'll ask our presenter to just comment on the results.
So this is disappointing. I was expecting, maybe I need to give back the salary. My efforts to educate people hasn't worked. Yeah. So once someone has treatment failure, the most important thing is to find out why the person has failed. That's the first thing to do. Do they have treatment failure? If it's yes, why have they failed? And you don't collect a genotype unless you know that this patient has been taking the drugs, and you have an idea what is the cause of the treatment failure. So collection of the genotype is the last thing you do. Yeah. So, and the reason is that when you're doing a genotype, you are trying to harvest the virus that is resistant. So you can only harvest the virus that if that is more than 20% of the population. So if the patient is not taking the drugs, the wild type, the virus that is not resistant, they'll overgrow, like weeds. They'll overgrow, the virus that's resistant, and you'll be harvesting the virus that is not resistant,
Okay. Thank you very much, Dr. Sivile, for your comments on the two core questions that we had projected. At this point, I'll just invite maybe one or two comments from our participants before we go into discussing the case for today. Do we have any questions or clarifications regarding the presentation? From our spoke sites and those that are joined in as individuals, do we have any? Okay. Maybe.
So Dr. Sivile, I know you are just coming from F&Q. I know your second poll question was just trying to check if people knew how rarely we actually ask for genotypes. Give us a sense, how many patients do we have on first line, second line, third line?
Okay. Can I answer?
Yes,
okay.
Go ahead.
Yeah. So for third line patients, we have about, Anita is here who are looking at those numbers. We actually, third line, we have about 425 patients, somewhere there, right?
Percentage of the total.
Yeah, so I'll start with the absolute numbers. And I just wanted to mention that patients on third line, they do very well. So from the time the program started, the data shows that, about 75% of the patients are still in care. So the attrition is very low. It's very low, so they're doing very fine. So to find the percentage, you can 450 over 1 million. So that's a very small number, that transition to third line, on third line. And second line, we know the figure is like 2% of the population are on second line. Yeah.
Which population?
Of the HIV population, the PL-HIV, those on treatment, 2%,
Okay, maybe just a follow-up on that one. So does that include pediatrics and adults as well, or we are talking about adults only?
I think that included both, Anita, right? Yeah, that's both.
Okay.
Yeah.
So, Dr. Thomas, maybe you could give a comment regarding treatment failure, and even just in passing, one or two comments as we wait for Sons of Thunder to share the presentation.
With the pediatrics, one thing we have to emphasize is that those children who are not disclosed to, they have to be disclosed, because otherwise they won't understand the seriousness of being into a third line regime. The other thing is the drug administration in children, it depends on a committed caregiver, because the third line drugs are always bleeding regime. We have situations where it's a single mom who goes to market very early in the morning, coming back very late. So we have to sort out the family and other social issues so that we have to fix a time which is convenient for them. We had situations where it is not possible. If the CD4 count is very okay, we leave them even on monotherapy with 3TC until the circumstances are okay to start third line. Just a few points on that. And the other thing which I want to verify is, suppose someone has stopped the ARVs. If we want to do a drug resistance, we have to restart the drug and wait for minimum 2 weeks or 4 weeks. I just want a clarification on that.
Dr. Sivile, perhaps you comment on that one.
Yeah.
on how
mutations from people who are on PrEP. And I think the conclusion of that study, I think we'll have some time to present that to Croy. It was most of the people who actually do develop mutations are those who are started on treatment when they are positive. As you know, our determine or whatever test has got that 3 months window, and if you can't screen the patient properly, you might start someone who is on who has acute HIV, and that's been documented that actually it is a risk.
Okay, so thank you very much. We apologize, we got disconnected there for a few seconds, but we're discussing the possibility of developing resistance for those that are on PrEP and then end up being HIV infected, and that's what Dr. Sivile was responding to. So, Dr. Agre and the team, Sons of Thunder, are you ready to share your case with us?
Yes, we're ready.
Okay, please go ahead and share the slide. Okay.
Okay, can you see and hear me?
Yes, we can.
Okay,
Finally, use slideshow.
yes. Do you have the slides too?
Yes, we can see the slides, but I want to use slideshow.
Okay,
Thank you very much.
thank you.
So you can go ahead.
Yes, I'm starting now. The history was a 40-year-old female. She was initiated on ART on 3 November 2011, and she was initiated on TLE. She was transferred to us on 13 May 2013, and when she came to us, she was on AZT, 3TC, and lopinavir. We had no idea from the transfer papers when her regimen was changed. We had no idea why it was changed, and the patient pretty much couldn't tell us anything either, other than they said, here, take this. Her husband died in 2012, and from what we know, died at home, and nobody knew the cause of death. Her past medical history, there's nothing significant. She is still unmarried. Currently, she does not have a sexual partner. She has 4 children. The youngest is 4 years old, and that was from a gentleman who came visiting the village, got her pregnant, stuck around for 2 months, and nobody has seen or heard from him in 4 years. According to her, and the one child that we are definitely aware of, all of her children are negative. The most recent, CD4 count in May of 2018 was 593. We just completed one on 1 March 2019, and it's 1,230. Her viral load, the initial one, was done on 7 September 2018, and it was 62,741. And the most recent one, also done on 1 March, is 121,000. HB, same day, was 12.3. In all the time that we have been treating her, we have done 10 CD4 counts on her, and none of them have been below 400. The physical exam at her last visit, healthy appearance, BP was 123/80, height 153 centimeters, weight 51 kgs, temp 36, pulse was 89. Rest of physical exam was normal, nothing significant. So basically, where do we go from here? Should we be looking at referring the patient to an advanced level treatment?
Very much, Sal and the team, for that case presentation. I think in summary, we have a 40-year-old female who has been on ART since 2011. Initially was on tenofovir, lamivudine with efavirenz, but was switched to second line, which is zidovudine, lamivudine with opinavir in 2013. At the time of the switch, the reasons were not clear. And this lady has been receiving treatment since 2013 from Sons of Thunder. Of note, she is currently unmarried. Her husband died about 7 years ago. She has 4 children who are all HIV negative. So the issue here is this lady has had 2 high viral loads, the first one being done in September 2018, which was 62,741 copies per mil, and a repeat one, more recent, done on the 1st of March this year, 2019, which was 121,000 copies per mil. So they have 2 questions. Where do we go from here? Should we refer the client? And what regimen can this client benefit from? So before we tackle the questions, I will invite any clarifications or comments from the network. You can stop sharing your slides. Agre and the team, you can stop sharing your slides.
So the question here, you can see it.
Okay. Do we have any questions?
There's one there. Can you see? Up there. Oh, you can't see it.
You can see it. Okay.
You can't see that only the slide section.
From the hub, do we have any clarifications? Okay. So,
Hi, Agre.
Thunder.
Sal, please stop sharing your screen. Just go up. There's a panel that says stop share. Thank you.
Okay, thank you very much. So, Dr. Thomas, you wanted to clarify something?
Yeah, I just wanted to find out, is there any other previous viral load results apart from these 2? And after seeing the first viral load, which was high, any EAC done?
Okay, so Dr. Agra and the team, we have a question from the hub. They want to find out if there was any other viral load that was done before the first one that was done in 2018. And if this client was enrolled in EAC. So you could quickly comment on that.
Okay. We had just started doing viral loads in 2018. Can you hear me?
Yes.
We had just started doing viral loads in the 4th quarter of 2018. And as far as the enhanced adherence, yes. And this is one of those patients that I have no doubt that she takes her medicines.
Okay, thank you very much. I think there was another question. They wanted to find out if this client was enrolled in enhanced adherence counseling after you got the viral load results.
Yes.
Okay, so was it after the first viral load result or the second?
After the first.
All right, thank you very much.
There's a question from Onoya. Dr. Kandio, he says, my concern is as follows. Index testing should be conducted on all patients with high viral load results. should we commence the sexual partner on the same regime than the potential source of transmission or on the first line?
Okay, so we have a very good question there. Dr. Mpeta, would you kindly share your views on that?
I didn't.
Yeah,
Right,
like
get
two questions in one.
Yeah, so sorry, maybe if you could start with the question.
He says he feels that index testing should be done on all her partners because she has a high viral load. And his question is, should we commence her sexual partner on the same regime than when the potential source is actually resistant because of the high viral?
All right, okay. Yeah, so first of all, yeah, like it has been rightly, I know the primary doctors are very confident that this patient is taking drugs. However, if I'll draw your attention to the lab results which you have given us, if we look at this patient's CD4 count, it's actually improving, which is it's going up from 593 to 1,230. Equally, the viral load is also going up. So the question is that what's happening to this patient? This patient, yes, could be taking drugs, but looking at these results, this is indicating that there's somewhere where there's suboptimal treatment. So either the patient takes the drugs once in a while, which is resulting in the viral load going up, and at the same time, trying to maintain the immunity, or this patient would have had, number one, first of all, it's adherence issues. And adherence, like we said, compliance has to come in. And then the potency of the drugs as well could be question of what she's receiving. We don't know about previous exposure to single dose verapine if it was there. This patient, as we have seen, is on a second line, and she's having that viral load. So I think we really have to interrogate the issues of adherence and compliance. So this patient should actually be placed on intensified adherence and counseling, and if possible, actually directly observed therapy. And then we repeat this viral load, because it's not making any sense that the viral load is going up and then the CD4 is also going up. At least the CD4 should also somehow start falling if this patient is failing treatment. The other issue is we have to look at the type of, apart from, sorry, the other issue I wanted to know is for how long has she been on this second line or prior to transfer? I know you said that I came in with the second line, but for how long? And the reason we need to really even take a history from the patient, why they were changed to second line. As we know, second line is a higher pill burden. And let's also look at how the patient is taking this drug. You may find that sometimes you give them two types of drug, then they'll take the first type. When it finishes, then they start taking the second type. That can also give you this type of a picture where you have a high viral load or a worsening viral load, but the CD4 is not really, really bad. So we have to also ask about how tolerable this regime is to the patient. So there are a number of issues I think we need to interrogate before we actually pronounce this patient as having failed second line. There was the aspect of the partner being started on another regime. I think the previous question, like I think as it has been highlighted, we cannot confidently say at this point that this patient has actually failed second line. So probably she has some first line, probably maybe she failed first line, or she hasn't even failed both first line and second line, because we don't know the reason why she was changed, and if at all there was any suspicion of treatment failure, or was it because of an error in prescription. So there are a number of issues that we need to interrogate in this patient before they are pronounced as having failed treatment. So the partner, sexual partner to this patient, if they are infected, I think I'll be comfortable to start them on a first line as well, as opposed to starting them on a second line. My thoughts.
Thank you very much, Dr. Mpeta, for your contribution. Do we have any other question from the participants or the spots before we go to the questions that our colleagues from Sons of Thunder have raised today regarding the case? So quickly, do we have any comments? Okay, so I think we'll go straight to discussing the questions that they have today. And the first one is, where do we go from here? So they want to know what they should do after this. They have a high viral load, 2 high viral loads, in fact, on a patient who's been on second-line ART since 2013. That is for more than 6 years, or close to 6 years. So Dr. Sivile, would you like to comment on that?
Yes. Since I'm put on the spot, I'll comment. Yeah, so this is a typical case that we would receive in third line and clinic, and I have a lot to say about this case. Yeah, so where should you go from here? The answer, should you refer this client to third line, to ATC? The first answer is the client, no. I think the client cannot be referred. But the client does meet the criteria of someone who's having second-line treatment failure. Now, usually when you're given a case like this, which is incomplete, there are some details that are not here. It's very difficult to make sense out of the story. So the story that we have is that it's a 40-year-old woman who was started on a tripler, I believe at that time, in 2011, November. And just over a year later, the patient was on second line. So the details, what happened within that first 1 year of treatment is very important and will determine the subsequent therapy this patient should consider. In my opinion, we know that, tenofovir resistance in the first 1 year occurs in about 50% of patients. So it's not so common, in other words. I mean, it's a 50-50 case. If someone just takes a tripler for a year and then they've developed resistance and we don't know why, and this probably suggests what Dr. Mpeta is saying, that maybe this patient wasn't taking the drugs at that point, So why did this patient fail the first line? That's the first question that we can't answer, And was there really mutations to the first line treatment? So tenofovir relatively has a relatively high genetic barrier, like I've said, only 50% will have resistance at that point. Then this patient was put on AZT. There are questions like, did this patient have, drug-drug interactions? Was this patient ever on TB therapy? I don't know the answer to that question, but it's very important. We know that the commonest cause of treatment, the 3 commonest causes of failure is adherence, drug-drug interactions, and inappropriate sequencing. The sequencing seemingly was fine, but did the patient have some drug-drug interactions? I would like to know if the patient had TB. So this leaves probably the issues of adherence. Obviously a patient like this, adherence is a complicated matter when you're dealing with a patient. Just asking them if they take their drugs, it's nice. But the question is, did they stop their drugs at some point in the past? You have patients come in the clinic, the last 2 years they've been taking the drugs. 2 years ago, 3 years ago, they were not taking drugs. And if you look at this history, that the information that we have, there are some social issues that are coming out in this patient. This is a patient who lost her husband in 2012, then on therapy. Was she taking the drugs at that point when she had a bereavement? My guess, is as good as yours. Probably she wasn't, and that's the time she failed her first line. The second question is, this patient had a child, 4 years ago, apparently after she lost the husband. Today it's 2019, 4 years ago, that would be 2015, right? Yes. Did she have another partner? You know, what happened there? Was she taking the drug? So that these social issues that are coming out in this patient's story, which we can't explain. And I tell those who accompany me in students that if you meet a man, he's failed second line, it's job issues. If you meet a woman, the failed second line, it's love issues. And that principle, you know, is very true. You'll find it in clinic. So this is a patient who the last 8 years or so has had several partners. So, you know, there are issues there. You know, there are issues, and I doubt if I'll be convinced that this patient has been taking the drugs. So where do we go from here? I think this patient needs a genotype, and it's crucial in this patient, especially that I anticipate that the patient didn't really develop resistance to genotype for the reasons that I've told you. The time that the patient failed the first line is the time that the patient had a bereavement. Obviously, she stopped the drugs. And this would be a very good candidate to be put on TLD, you know, because likely that the tenofovir is still working and the dolutegravir might work. Maybe she's come out of all those previous issues, you know, social issues that's experienced. Now she's willing to be on therapy. But the only guide we can have is a genotype. So my recommendation is we do get a lot of genotype samples at UTH from Livingstone. Dr. Ngongo knows how to send those slides, those samples very well. This patient can go there and send a genotype to Lusaka, and we'll send back the result. For now, patient has got good CD4 count. It's time to improve the adherence. You know, this is not a patient you would worry about, you know, because the CD4 count is still fine. So they do have some 3 months, 4 months, you know, even on not so effective treatment, because the CD4 count is fine. We can wait for the genotype, it comes back. And if tenofovir is still, you know, susceptible, this is a good candidate for TLD. Yeah. Dr. Foloshi, I don't know if you have that.
Thank you, Dr.
So those are my comments. Yeah.
Dr. Foloshi, quickly, do you have a comment on that regarding what has been discussed so far?
Wow, interesting. Anyway, I guess that gives people an idea of the sort of patient journey people are subjected to when they come to third line. You can imagine they are coming from as far as Southern Province. You stop the ART because you think it's not working. When Dr. Sivile sees that patient, he will do nothing aside put the patient back on treatment and offer counseling. But I have a question. I'm a bit on the fence on this one. What is your comment on the log drops in her viral load, or the way it's increasing in that pattern? And the other issue is, even if we genotyped her, do you think the case last week tenofovir years ago? So we are risking archiving, isn't it? So we may not see it. So we need to bear that in mind even when we genotype her. But what's your comment on the log increase?
Dr. Sivile, you can quickly comment, and then we'll try and get a comment from Dr. Paul Zulu as well.
Paul Zulu, okay. Yeah. The increase, yeah, like I've said, I think this patient has failed the treatment, and I think she has mutations and the viral loads are going down. I think she has PI mutations. She has some NRT mutations. I think she has all those, you know. But, you know, that 1 year that she took TDF and the bereavement makes me think that probably she actually didn't fail. The 1 year was a bit too short, and I would give a chance. Yeah, obviously, to be nice to see the genotype, it will give you more information what is going on. Yeah.
Okay. Thank you, Dr. Paul. Could you quickly comment on the case? So we are dealing with a 40-year-old female, who's been on ART since 2011. Was on first-line therapy for what seemed to be like 1 or 2 years, and was switched to second-line ART. And the reason for the switch was not so clear. we're anticipating there could have been some social issues at that time, because that's the time she had lost her husband. And now she has 2 viral loads. The first one was more than 62,000 copies per mil as of September 2018. And the latest done in March, the 121,000 copies per mil. So could you kindly comment on that? So our colleagues from Sons of Thunder had 2 questions. Where do we go from here? They need to refer the patient. And what regimen can the client benefit from? Dr. Zulu. Dr. Zulu.
So actually, I've just gotten a message. Okay.
Okay. Oh, Dr. Zulu, we can't get you. Kindly speak up.
Thank you.
Closer to the microphone.
Yeah. Dr. Zulu. Dr. Zulu, kindly move closer to the mic if you can. We can't get you clearly from the hub. Okay, Dr. Zulu, unfortunately, we can't get you clearly, but I think we'll ask for comments for now from Dr. Klassen. Dr. Klassen, would you like to comment on the case, please?
Hi, good afternoon, everyone. Thank you for this opportunity. I would agree with Dr. Sivile. I think that there is a remarkable opportunity here for disengagement in care due to social stressors. And I think that his comment on the recent bereavement is well put. I agree that TLD would be a good regimen for her, but in this scenario, genotype would be well suited just to guarantee knowledge of what's happening, given some uncertainties around the case. So I would favor those approaches. Thanks.
Okay, thank you very much, Dr. Klassen, for that comment. Before we wrap up the case, maybe Dr. Mpeta, would you want to comment on the second question? What regimen can this client benefit from? As of now, what should they do?
Well, I'm a little biased with regards of saying this patient has absolutely failed. I think from experience, we've seen such kind of patients where probably if we go to a home environment and exactly as anybody checked how she's taking the drugs, because that's one of the issues I think I'll be very, very, straight. If this patient is correctly taking the drugs and there are no other drug interactions, then probably that's when we can say, okay, this patient has failed treatment. As discussed earlier, a genotype basically will show us the mutations of the current regime that is there, and probably we might or we might not see NNRTIs and TDF, but looking at the potency of TDF and the circumstances in which she was switched, this patient could actually benefit from the current first line, which is TOD, looking at how the patient is presenting. With regards to a complete third line, I'm still not convinced that this patient is an absolute candidate for a third line, especially that if this patient has been failing for this long that they have showed us, by now we could have had some, opportunistic infections. The CD4 could have started going down, but the CD4 is fine. This patient has been fine. So I really, really doubt that this patient has absolutely failed this treatment for this long without showing all these, expected adverse outcomes of ART. So for now, I think the first step, where do we go? I think we have to assess how she's taking the drugs, and somebody has to directly observe. And then we also have to inquire about use of, African medicine as well. We might not know what she's taking. And then that's when we can send a genotype for this patient to come. Or they can do a genotype, because a genotype is definitely going to take some time. They can still send a genotype now and then maintain on the same second line ART that she's on, but emphasizing more on the adherence and how she's taking the treatment and any other circumstances, including drug storage. We have to know how she's storing this drug at home. It's important that we just understand all these circumstances that are surrounding this patient. I would not be quick to start her on third line because I just don't see it from the picture that has been given so far.
Thank you very much, Dr. Mpeta, for that. I will take one last question from the hub, that's from Anita, and then we'll wrap up the case. So Anita, just go ahead with the question.
Good afternoon. Dr. Sivile, I wanted to find out what you think about HIV-2 when it comes to treatment failure. I noticed you didn't mention it. Is it worth talking about? Is it worth testing for in patients whom we don't know whether they're adherent or not? Is there like treatment failure when it comes to HIV-2, and how do we deal with that?
Okay. Yeah, thanks, Anita. The issue with HIV-2 is we are not able to do the viral loads for that, much less the genotype. I don't know if there's even a technology to do that available. But we actually do get concerned with or suspicion for HIV-2 if the patient is known to be HIV-2 infected, you see. Secondly, if the patient is not failing HIV-1, but the CD4s and the clinical picture is speaking otherwise, then you think, okay, they are failing immunologically, they're failing clinically, but virologically they are not. So is it because there's another virus at play? Then we ask for an HIV-2 viral load, which is done from private labs, and then you can assess in that.
Okay, thank you, Dr. Sivile, for that comment. I think we are going to wrap up the case. We've had a very interesting discussion. We've heard from our subject matter experts, infectious disease physicians. I think Dr. Mpeta has one last burning comment. So Dr. Mpeta, I'll give you two seconds.
Yeah, I think it's a clarification on the earlier comment I made about a person who gets infected from somebody who is failing first line. Yeah, so I think, yes, if we are able to prove, remember that there are certain tests that you have to do to know that the source of infection is this one. So most of the times we'll make the assumption that this is the source of the infection, or this person was the first one to be infected rather than the other one. But in the same sense, we know that there is infection and reinfection. So yes, if a patient has got proven treatment failure, their partner also has to be considered, especially if they also start failing. But remember, like we say, if it's not broken, don't fix it. So if the sexual partner is on first line, while the other sexual partner is on second line, and both of them are suppressed, there is no need to actually change treatment in the other person who is suppressed. So only if the circumstances are present, such as the sexual partner is infected, if they are a new diagnosis, and we can prove that this is a new diagnosis, probably the source being the index person, and the index person having confirmed treatment failure, then we can consider changing the patient onto an effective regime. Now, in this patient, I said that the partner could actually benefit from TLD as a first line, because if we look at the time period it took to fail tenofovir was too short. From what we know in experience, tenofovir shouldn't have failed. And then this person is on second line. So if they were to transmit, then it means that the tenofovir is still working and the dolutegravir is still working. So you are still going to have two powerful drugs that are still working, that the sexual partner could still benefit. And that was why I made this comment. But in any other circumstances, remember, patients are different, and that's why we are emphasizing on a history taking. In any other circumstances, we have to prove that the index is really the source of the infection, and then there is actual treatment failure. Then the contact person will need to be put on an effective ART rather than starting them on the first line.
Dr. Camille, do you want to summarize the recommendation?
Yes, so thank you for that clarification, Dr. Mpeta. I think I'll just quickly summarize the recommendations arising from our discussion so far. And I think what has come out is, first of all, we have to make sure we look at the history, the social history of this patient, because this may influence her adherence to therapy. So the second recommendation was that we optimize adherence, make sure that she is actually taking the drugs as prescribed. For now, we recommend that you continue with the second line ART, and instead of referring the patient, you instead collect a sample for genotyping and you can send it over to Osaka. I think Dr. Sivile has given us a guide on how that should be done, and we can also get more info from the lab personnel. I think for now, that's all we had to discuss. I just want to find out from Sons of Thunder regarding what has been discussed so far. Do you feel you have been helped, or do you still have clarifications or one or two questions?
Yeah, I'm glad you clarified things at the end, because I was getting confused. Do we go to TLD? Do we just do genotyping? Are we throwing a little bit of this, a little bit of that? But what you laid out makes sense in the respect of maintaining the current treatment, do the genotyping, and then see where it goes from there. There seems to be confusion. There is no partner. He was in the village long enough to get her pregnant, and then he's gone, never to be seen or heard from again. Sorry to say, but we have a lot of gentlemen out here that bounce from one village to the next, spreading their happiness. But the suggestions are very good. And we will get the genotyping done through Livingston. And then
Okay, thank you very much. I think with that comment from Sons of Thunder, we can wrap up this case and today's session. I just want to thank all of you for actively participating, and those that also just joined in and were with us and listened to the discussion. I hope that this has been beneficial. We know we don't talk about second-line treatment failure often, but I hope now we have some guidelines and principles of how to go about managing patients that are failing second-line. Okay, so Dr. Sivile says the guidelines are available. We'll try and find a way of actually circulating them. So I think I will ask Nomsa if there are any announcements for today.
Yes, thank you so much. Thank you so much for everyone for participating. We just want to make one announcement. Next Monday is 22nd, and that is a holiday. It's Easter Monday. So I wanted to inform the network that we will not have an echo session on Monday the 22nd, but we will resume echo sessions on Monday the 29th. And please would like you to join in on the 29th. We have a very interesting topic that really ties up with what we've been discussing, and that is championing viral loads. So we look forward to you joining in the next session on the 29th of April. See you then. Thank you so much.
Thank you. And we are done.